Assalamu alaikum everyone. We're glad everyone making here today. As you all know, this is part of Alfaisal Mini Med-School Series lectures, and this talk will be highlighting the field of medicine that is underlined, that is very important for a specific age group, and that is geriatric medicine. We will also be focusing specifically on dementia, as we will go over its workup, diagnosis, management, etc. with our guest speakers. And so before going forward, I just need to introduce to you the website that we're using to integrate you as the audience with us during the presentation. So that's menti.com. I just need you to go to menti.com and enter the code, or you can simply scan the QR code that you're seeing here. Or if you have the one pager, you can just scan it on the one pager, the QR code. And click on the thumbs up once you're in so we can know how many participants we have. Okay, so we have a good number, we can start now. So I'll just do a sample question to see how you guys are familiarized yourself with Menti. So what age group does geriatric medicine cater to? Okay, so that's correct. Okay, now proceeding to the presentation. Our guest speaker for today is an Alfaisal alumni graduating from the first batch of medical students. He completed a Master's of Public Health from Johns Hopkins, followed by an internal medicine residency and geriatric medicine fellowship at the University of California. Thank you so much, Dr.
Yeah, of course. I'm at your service. Thank you for the lovely welcoming and introduction and the beginning slide here. I'm very excited to be here today and present to you. Ignore the multiple wires and mics on me. I'm actually one of the first year graduates from Alfaisal University, so I'm very, very enthused and excited to present to you today about this important topic that I think is important for my field of medicine. I finished my training in internal medicine in Canada, followed by geriatric medicine and a master's in public health from Johns Hopkins. And I work with the Ministry of Health quite frequently regarding geriatric medicine, public health, and older adult health in the kingdom across multiple models of care. But enough about me, let's start with the presentation. So I think we will go over these objectives with a very interactive session with the group we have here as well. Thanks to Ziad and Main's group who did a fantastic job. The handout you have with you, the one pager, I think is phenomenal. So take a look at that, and I'm certain you're going to benefit from it quite a lot. So with that, we can start with our objectives. So define and articulate what geriatric medicine is, my field of practice. Express rationale, needs and benefits of geri medicine. Explain the definition, burden, and types of dementia. Discuss the workup and diagnosis of it. And then finally, some management aspects, both pharmacologically and non-pharmacologically. So, geriatric medicine. And I will defer to you.
So to make it more interactive, we will have 50 questions throughout our session for today. You can use this code if you have get locked out from the Menti. So the question said, what do you think will happen to the population age groups in the upcoming years in Saudi Arabia? So,
and just to clarify, all of your inputs are anonymous. We won't save any of your information. We can't even do that anyway. So, but I think it's going to be quite fruitful to have your interaction with us today.
What do you think will happen to the population age groups in the upcoming years in Saudi Arabia? Wait for 40 inputs. Okay, Doctor, what do you think about the answers?
I think that is correct. So percentage of people age 60 plus is expected to rise significantly in the kingdom. We're a very young population, and I'll explain that in the next slide actually, if we go up next. If you want to make that full screen and go back to the... Perfect. No, we're good. I got it. Okay, so this is a population pyramid of Saudi Arabia, and as you can imagine, we're a very young population. So the majority of us are actually under the age of 32, which is quite impressive. So 50% under the age of 32. We're very young. That's all going to change with time as we age and grow. In fact, it's quite impressive. The Saudis' life expectancy jumped by about 7 to 9 years in one generation, which is quite phenomenal if you think about it. And it's only going to get better and better with time as medicine progresses. So just to orient you about this population index you see here in front of you, the y-axis is the total population in percentage, and then the x-axis is the number of years. And as you go along with time, according to the UN, and by 2035, you're going to see a significant increase in older adults age 60 and above, as younger adults tend to dwindle down. That's about the generation between mine and the one above me. If you have an older brother, perhaps that generation is going to be quite old later on. So again, this whole thing is going to flip, and you're going to have significant older adults down the line, which has significant burdens that comes with it. And we call that the tsunami of the 21st century healthcare, is what some authors prescribe in their studies, meaning that there's going to be a significant burden to both healthcare, to families, to yourselves as we all age, and a significant burden in financial support for them as well. Beds in hospitals, home care facilities, long-term care facilities, medications, these are all going to amp up significantly as we age and need to treat their chronic long-term illnesses. So Geri medicine. So this is my field of practice, and essentially it's an extension of internal medicine, or طب الباطنة, and what that means is it incorporates complex medical issues, so all their past medical histories, despite how complex it is, they can easily have 5, 10, 15, 20, without exaggeration, coupled with complex medications, and they also have functional decline as well on top, maybe some cognitive decline as well. So it's up to me to reverse engineer all that and address all those issues, keeping in mind their values as I treat them, which is fairly difficult to do, but I like it. Also some elements peppered in of neurology and psychiatry as well. So again, I love the breadth of it. And it's a growing need in a very vulnerable population. So many older adults can't speak for themselves. Some have dementia, some have delirium, some have functional decline and can't ask for help, if you will. Families have caregiver burnout. A lot of ripples and effects in communities where you see older adults suffering, but not a lot of it is being spoken of. And again, it's not a big tumor you see, it's not a big GI bleed you see, it's all insidious and chronic. So to summarize what Geri medicine is, it's holistic, it's multidisciplinary, so I'm dependent on a lot of allied health members, meaning the pharmacist, the dietitian, the physical therapist, the occupational therapist, a charge nurse, a case manager. All of these other members in healthcare is important to address all health needs for older adults, not just a single system-based approach, cardiology or nephrology, and then have a good day. No, I look at the general picture to address all their health needs, regardless of what it is. And it's patient-centered, which all specialties should be, but in particular Geri medicine, because you're addressing their end-of-life values more so than anything else. And a quick summary, this was coined by a famous author. It's called the 5M model overview of Geri medicine, which just summarizes to you what Geri medicine is, if you tend to forget, if that was a lot of information. So mind, mobility, medications, multimorbidity, and matters most. So mind is for diseases such as dementia and delirium and making sure they have a healthy brain. Mobility is what it means, so avoiding falls, avoiding them being bed-bound, avoiding being wheelchair-bound. Medications, and as it comes with many complex aspects of side effects, drug-drug interactions, drug-food interactions, side effects that they can't tolerate. Even though it's evidence-based to give that medication, maybe for them it's not, because it can cause significant burden to them. I'll give you a quick example I'm just going to come up with. So beta blockers. A patient with cardiac disease should be on a beta blocker technically, but if they're falling quite significantly because of it and they're always tired and fatigued and their heart rate dips below 60, sure, that may improve their mortality and survivability, but you may not prescribe that to that particular patient if their quality of life dips because of it. And that's a discussion you have with them, whether or not they want to pursue that or not. Multimorbidity, again, complex medical issues all intertwining together. And then matters most, their values, as I alluded to before. And there's a whole breadth of issues that we, or aspects that we are referred to for older adults. So as I said, complex issues, polypharmacy, dementia, delirium, Parkinson's disease and all its subtypes, falling, frailty, functional decline, sleep disorders, unintentional weight loss, caregiver burnout, and end-of-life and palliation, which is very underrated, especially in the kingdom. But as you can see, a wide breadth of referrals that I receive, both inpatient and outpatient services to supply with my patients who have these complex issues, and they have more than one of these combined. This is just a quick overview of one of the key important tools that we do in geriatric medicine, which is called the CGA. It's the Comprehensive Geriatric Assessment. And essentially, it's these 6 domains here that can take quite a while to assess a patient for. Again, either inpatient or outpatient. So starting from the top right here, so you have geriatric syndromes, so the functional decline aspects, the falls, the frailty. Mental health disorders we have to review as well. Functional history, so what they're able to do during their day of basic activities like showering and eating or doing their finances. Medications, if they're able to take them, what we need to change. Cognitive history, so that's a very big assessment into their cognition and mind and thinking. Social history, which isn't just if you're smoking or not, it's your level of education, your occupation, your marital status, your living environment. And then finally, history and collateral history, I think is very, very important. And collateral history means the history that you get from a loved one or someone who knows them quite well, health-wise, and to gather information from, which is a very important aspect in geri medicine. So this is called a CGA, just the main elements and overview that I apply in my field. It's been well studied. It has significant benefits. The main ones being, and I won't go through this to bore you, but the main things to mention is doing a CGA, which can take up to an hour and a half to 2 hours, by the way, in the clinic, and as an inpatient maybe a bit faster, but overall quite a long time, as you can imagine, relative to other consults, which can take 15, 20, 30 minutes perhaps, so a triple, quadruple the time, is that it's been shown to keep patients alive, older adults, alive and at home for at least up to 1 year. And the studies are very heterogeneous about this, so it's tough to assess for quality of these studies, given that you're assessing, being alive and at home with how functional you are. But essentially, that's the main takeaway from this by applying that CGA, which is very easy to do. You don't need fancy equipment or tools or money to accomplish this task. Other benefits is that it improves quality of life and satisfaction, reduce readmissions, reduce family burnout, delay placement, honor end-of-life values, is very cost-effective. In fact, it saves a lot of money, not just for the patient, but also in terms of healthcare overall. Because if you can imagine, you're preventing readmissions into the hospital. If your loved one, grandma, grandpa, or father or mother, are being readmitted again and again to the emergency department, not just the cost for the hospital, that's secondary, sure, but also burden for them in terms of quality of life. If you can prevent that from happening, it's a win-win from a society and individual level. And reduce frailty progression, which I won't talk about too much for the sake of time. So just the status quo about Saudi Arabia right now and what geri medicine entails. So it's very new. I'm actually only one of 10 geriatricians in the entire kingdom. So I'm like a unicorn in front of you right now. But overall, there's a subspecialty, or نسميها أخت الجeriatrics, or the cousin of geriatric medicine, which is care of the elderly. So it's a subspecialty after family medicine. I think a lot of you are going to go into family medicine, I assume. And so you can do a 1-year fellowship in that. Currently, none of it's offered in the kingdom. And I'm working currently with the Ministry of Health and the National Guard Hospital to initiate the first fellowship training program in geriatric medicine, but that's a subspecialty in internal medicine, not family medicine. So these are 2 separate programs, still not offered in the kingdom, but inshallah soon. There's a lot of funding going from the Ministry of Health about geri health moving forward. We're creating consult services, establishing clinics. We're reforming home care. I'm involved in one of the main committees in the Ministry of Health with home care, and that's a service that goes to families' homes directly to care for them. Again, you want to avoid coming into the hospital and care for their needs as much as possible without coming into the emergency department. Educating healthcare professionals, I'm doing that right now. And educating the public, I'm doing that right now. So I'll defer to you, Ziad.
Okay, so on to the next question. So what are the words that pop in your mind when you hear the word dementia? You can enter one phrase, but if you want to enter a phrase that is 2 words, you need to use a dash or a hyphen.
Yeah. Do you want to read off some of the words?
Okay, so memory loss, forgetfulness, confusion, degeneration, brain damage, What do you guys think? What do you think about them? Are they words that are related to dementia?
Yeah, of course they are, yes. And the reason we're bringing this question up, and thank you, Zed, for this very intelligent question, is because there's a lot of misconceptions and myths about what the word dementia means. بالعربي الخرف. I don't like that term because kharaf technically means one who speaks gibberish, which is a little bit insulting. Like the word moron used to be a medical term, or retard used to be a medical term, but that's changed with time socially to be more appropriate. And hopefully with time we can avoid the word kharaf maybe in a couple of years. But overall, kharaf and dementia are the same. And we can elaborate on that over the next slide if you want to go back. Okay, excellent. Yeah, you're good. So dementia overall, it's a very broad term. It's the umbrella term. I want you to think of it as an umbrella. That's the big term, and there's many subtypes of dementia, right? And I think that alone enough to explain to you is a big leap ahead as to where people stand with this, because patients who are diagnosed with dementia, their families don't even know this. Some physicians don't even know this. So dementia is the big broad term, and you have many subtypes under it. The most common type is Alzheimer's dementia, exactly. You guys don't need me, you're doing great. And so after that, so the term, there's the fancy medical term for it that no one uses, is major neurocognitive impairment, but again, that's still dementia. And this is not normal, obviously. It's not supposed to be a part of aging. And I know this sounds silly for me to mention to healthcare professionals or the public, but it's not normal. People think, I'm 70, it's about time I start forgetting things. That's not normal. In fact, a lot of people tend to think that. I started peeing my pants, I have urinary incontinence, that's normal. It's not. So again, to clarify, dementia is not normal. It's a disease and needs to be treated and diagnosed. This data is from Canada. I don't have any from Saudi. Inshallah, we'll start that soon. But about 5 to 8% above the age of 65 have dementia, and up to 30% above age 85 have dementia. And that's significant. That's 1 in 3. That's a ridiculous number, right? And it's only going to go up as we age, as I showed. And so for all you med students in here, as per DSM-5, so you need to have these 4 things to diagnose someone with dementia. So number 1, you have a decline in cognition. And cognition is the big fancy term for your functional thinking. أو بالعربي الإدراك. And people grab onto memory a lot as the key cognitive decline. And sure, memory is important, but you also have other elements in your cognition that declines as well, like language, visuospatial ability, your social abilities, your attention ability, your executive function, how to use a keyboard. All of these go down when you have dementia, not just memory. It must not be delirium, and that's a whole other diagnosis. I don't have much time to explain what that is, but essentially it's an acute confusional state where they're inattentive, and it tends to fluctuate, and it's secondary to a stressful trigger. So an infection can cause it, trauma to the brain can cause it, surgery can cause it, medications can cause it. And you treat the underlying cause, hopefully they go back to how they were before. They may not, but it's different than dementia. And you have to not have delirium to diagnose dementia. And if you do, which I get a lot of questions on, I tell them, treat the delirium, and I'll see them in my clinic in 3 months, and then we'll talk. But I can't diagnose it right now. It must not be a mental illness, because depression, believe it or not, can cause what we call pseudodementia. So you can have problems with your memory and language and cognitive domains because of depression as you age. And so you have to not have that. And if you do treat it, then reassess for dementia. And functional impairment, this is the key cornerstone for dementia. As we age, you do have normal age changes, but they're not enough to cause functional decline. So yes, you might be a bit sluggish, your processing speed goes down with age, but you should not have functional decline, meaning you should be able to do your finances, to take your medications, to shower, to feed yourself, to drive. If there's any issues there from a cognitive perspective, then you think about dementia as maybe an issue. We won't go through all of this. I know this is a bit overwhelming, but dementia types, as we said, Alzheimer's is the most common type of dementia. The second most common is called mixed dementia, which means Alzheimer's plus a vascular dementia. And vascular dementia just means a stroke of some kind. Either it's a clot or a bleed, doesn't matter. But a combination of Alzheimer's dementia plus vascular dementia, that's mixed dementia. That's the second most common type. The third most common type is vascular dementia purely, meaning you have a stroke causing dementia. There's other more rare types I'm not going to touch upon today, but I just wanted to showcase to you that there's many different types of dementia. As I said, it's the umbrella term. So dementia risk factors, and there's a lot of it. Age is the most important one, and we can't change that. Sunnat al-Haya, we're all going to age. We can't do anything about that. Family history is important as well, and typically studies relate that if you have a first-degree relative, so your mother, father, siblings, or children who have dementia, then likely you have a 2 to 3 times increased risk from the average person to get dementia. Not necessarily, it's just a risk factor. Uncontrolled hypertension, head injury, so trauma, if they had injury to their head multiple times, hypertension, diabetes, and by these I mean uncontrolled chronic illnesses, smoking, poor diet, high cholesterol, obesity, and mental health disease. The majority of these, as you can see, coincides with your cardiovascular risk factors. I'm sure you've taken in med school already, where you want to really improve the perfusion to the brain and blood supply to the brain as much as possible, regardless of the dementia type. And these are risk factors that would make that significantly worse. And back to you.
So, back to the Menti time, and once again, if you guys are logged out of Menti, you can just go to menti.com on the top of the screen and use the code to be part of this interactive session. So, this brought up a lot of discourse between our entire team, so we'd like to see what you guys answer. And the following question is, which of the following is used to diagnose dementia? Okay, so we have CSF, amyloid beta and tau protein, amyloid PET, MRI, or FDG PET. Okay, so we're seeing that the majority of you guys are choosing CSF amyloid beta and tau protein. So, Shane, would you like to tell them what the correct answer is?
Sure, and I think it's a bit unfair because maybe none of these are correct. So my apologies, or our apologies. I think the key cornerstone to diagnose dementia really is it's a clinical diagnosis. So that's unfair for us, but you guys answered pretty well. So CSF amyloid beta, that's and tau protein. These are markers that you have in your blood or CSF indicating potential dementia, but it's still in the research realm. There's a lot of practice now moving forward to make it more clinical and practical, but as you can imagine, you're not going to LP every patient that comes to you to get these markers for many reasons: cost, side effects, complications, patient refusal, and you don't necessarily have to have this in order to get dementia, and vice versa. So it's a terrible screening tool altogether. Amyloid PET, that's very fancy. I would not do that unless you're an expert in dementia, and if you really don't know what's going on. So don't worry about that for now. For your level, MRI and CT brain, and again, this is the most important thing I want to clarify to you, because a lot of my healthcare colleagues don't even get this correctly, is they think this is how you diagnose dementia. It's not. MRI and CT brain shows you the anatomical problems with the brain, but it does not help with diagnosing dementia because the degree of atrophy or thinness in the areas that would cause dementia do not correlate with dementia at all, okay? So you can't use it as a factor. FDG PET is very good. It's very expensive. I would not do it unless, again, you're an expert in dementia and you don't know what's going on, and there's many confounding factors. But the correct answer would be, it's a clinical diagnosis where you have to have a prolonged assessment for history, collateral, the 4 DSM-5 things I mentioned to you before, right? The functional decline component. And to help you, you could have cognitive testing, the cognitive testing tools, something called MMSE or MOCA, and there's like many, many others. And I'll leave it at that. I don't want to go into too much detail. So we're good. Okay, good. So, no Menti time, okay. Functional decline. Just to clarify what that means to the layman person, I'm trying to balance the public health aspect of this talk with medical students, and sometimes it's difficult to juggle both, make it more advanced for medical students, but a bit more layman for the general public. But functional decline basically means, as I said before, is a decline in your daily tasks, and we divide that into 2 aspects. So basic activities and instrumental activities. So basic activities I tend to refer to as things you should be able to do by the time you're in the 2nd grade. So walking, using the washroom, eating, showering, changing clothes, and grooming, if you're a very smart kid. Instrumental activities, again, more advanced, you should be able to do in college. I hope you can all do this by now, is cooking, managing your finances, driving, taking your medications, and housekeeping. And in dementia, you typically use your IADLs, your instrumental components first, because it's much more complex. And then with time, you lose your basic activities as it progresses, because it's a progressive, irreversible disease. It's important to note that sometimes it's tough to delineate this, because culturally speaking, not just in the kingdom, but elsewhere, you could have someone or a partner or a married couple who the husband does all the cooking or the finances, or the wife does all the driving, for example. And thus it's difficult to delineate if they really had decline in that or not. Or for example, if they stop driving, but not because they have cognitive impairment and they started having accidents, losing their way while they drive and getting lost and all that. No, it's because they have severe rheumatoid arthritis or osteoarthritis and they can't even grab the wheel. Those are two different things, right? If it's the arthritis one, it's not dementia. If it's the cognitive one, it may be dementia because you're losing your cognitive ability and your spatial ability to perform that specific task. So this is just a brief slide about, the y-axis here being the biomarkers that we talked about earlier, and the x-axis being time. And this should have a timestamp here, but this starts really early on, maybe in your 30s or 40s or 50s even. And then as time goes along, you have these biomarkers that are toxic to your brain build up with time. CSF, amyloid beta, amyloid PET scan showing you that there's amyloid deposition, tau proteins, all being toxic markers in your brain causing toxicity and thus neuroinjury and neuroinflammation chronically down the line. And then you have full-blown dementia with time. So currently the status quo, believe it or not, is we're intervening over here, which is very late. Your brain is already fried. Your brain has already developed all the injury there is. So to give you a quick analogy, if you had cirrhosis, right? Like anything, a lot of disease can cause cirrhosis or liver failure. Doesn't matter how you got there. But imagine me trying to intervene and fix your liver when you have cirrhosis. It's already fibrosed. I have to replace it. So hopefully in the near future, we can intervene way over here when you're normal. First, you have to know that they're going to get dementia, and then provide care for them. And I know this is sad, but 99% of the majority of studies published in the past 10 years have not been fruitful to develop a specific medication to treat dementia. And I'll talk about that briefly in a second. So this is a fancy MRI I'm showing you here, where, I labeled them, I was gonna ask you. So Alzheimer's dementia over here and healthy brain over here. I don't know if you can appreciate this with the lighting, but just over here you can see some thinness in the hippocampal. This is called the hippocampus. This is the place where your brain stores memories, at least initially, and then memory gets stored and inscribed in your brain throughout your cortex. But initially, at least, your short-term memory, at least, is stored here in your hippocampal area. And then this is called the mesotemporal area, just over here. And this is also helpful for memory and other tasks. So in this patient who has Alzheimer's dementia, it's thinned, it's atrophied, and in a normal person, it's not. Again, the take-home message is that this is not how you diagnose dementia. It's a very common misconception that's done even by physicians. And now you know this. This is the fancy PET I was talking about. So a PET scan is essentially a test that helps you see the degree of function in cells depending on their metabolism and glucose uptake. And so in a patient with Alzheimer's, as you can see, the uptake is very minimal, right? So someone who has a normal brain, very active, highly metabolic brain. Someone who has Alzheimer's dementia, really not so much. This is called mild cognitive impairment. I'm not going to chat about too much, but it's essentially a point in time where you have brain changes that are not normal for age, but not enough to cause dementia because you don't have functional decline. And about 10 to 15% of people who have MCI develop Alzheimer's. Not necessarily, but it's a risk, but also not normal. I'm not going to go into details, but just wanted you to see some fancy imagery today. So safety, wandering, people with dementia can open the door and just leave and get lost, which is an issue, obviously. Leaving the stove on, burning down their house, that's a big issue. Financial responsibility, someone could blackmail them, take their money, they might give out their money away. Driving, getting into accidents, hurting someone else. Medication adherence, if they're taking very important blood thinners for their atrial fibrillation or cancer treatment or what have you. Imagine if they decide to skip for 10 days because they forgot. Or they forgot that they took it and take it 10 times again. It's also an issue from a safety perspective. Caregiver burnout. This is also a very big aspect to talk about. As I said, the ripples of dementia go across all of society. If you are someone who cares for someone with dementia, then you are at 3 times the risk of getting depression because of it. Because the care needs of the loved one you're taking care of goes up, And so you will get depression because of that, amongst many other reasons, but that's just one of the main reasons as to why. And even for myself, I'm a physician who is doing jury medicine. If you ask me to look after a loved one for 24 hours in a day, I would be exhausted too. And I'm an expert in this, so let alone the general public. You address this by providing support to them, home care facilities, long-term care facilities, education, family physicians, and so on.
So this is the last meeting time, so we encourage everyone to just join in and answer. So in terms of management of dementia, what do you think about the following statements? So we want you guys to rate it from strongly disagree, like on a scale from strongly disagree to strongly agree, from 1 to 10. So the first one is antipsychotics are effective in all cases. The second is anticholinergics have been shown to treat dementia. Chronic illnesses do not affect dementia, and then non-pharmacological treatment is the mainstay of management. Once again, on a scale of 1 to 10, 1 being strongly disagree, 10 being strongly agree. My column is 1 to 5.
What happened? Yeah, 1 to, yeah.
Okay, so what do you think of these results?
You guys are very smart. Antipsychotics are effective in all cases. Hopefully the giveaway here was all, if you have any exam taking tips and strategies, but the word all here is a big giveaway. So no, antipsychotics are medications that are very strong and very potent and have significant side effects. Unfortunately, healthcare professionals give it out like candy, and you will see this when you start your practice. So don't do that. They're not magical pills. You give them for specific indications, namely if you have psychoses that are very distressing. And by that I mean you have hallucinations that are very distressing, that they don't know if it's real or not, and they think it's going to affect them. For example, if you have someone who has hallucinations or delusions, that they can say, I think it's real, it's not there, I know it's not real, or I see a dog, I see a cat, I see a kid, who cares? It actually bothers the family more than it bothers them. But if they see monsters, or if they see a criminal trying to attack them, or if they think someone's going to attack them, they're very paranoid, it's distressing to them, they have distressing psychoses, that's who you give antipsychotics to. Or if they're at risk of harm to themselves or others, that's a good reason to give them antipsychotics so they don't punch you. But only in those two main cases. A third good reason would be if they have life-saving equipment, like a line or in their neck, or a peg insertion for feeding. If they remove it, that's a disaster, obviously. So if they're doing that, then perhaps antipsychotics to chemically restrain them might help. But unfortunately, we see this quite often where they're given to almost everyone, which you should not. The side effects are plentiful. In fact, 1% chance of death as a side effect, which is ridiculous, and 2% chance of stroke. Again, that's very high if you think about it. Among many other side effects, I'm just mentioning the big ones. Anticholinergics have been shown to treat dementia. Absolutely not. This is the exact opposite. So you want to potentiate your cholinergic activity in the brain to preserve what little neurotransmission you have, and your muscarinic receptors and cholinergic neurotransmitters are the key aspects that help promote memory. And in fact, as you age, that's reduced significantly, and with dementia, it's reduced even more. And so one of the key things you do in dementia is you want to stop anticholinergic medications as much as possible. And many medications have anticholinergic activity, so you want to stop those as much as possible. Chronic illnesses do not affect dementia. They absolutely do. I gave you a cheat sheet before this. So like diabetes, hypertension, high cholesterol, smoking, all that. Non-pharmacological treatment is the mainstay of management. Yes, it is. So everyone should get non-pharmacological treatment, and I'll talk about that, I think, in the next slide, which is a good segue. If you want to go to the next. So dementia treatment overall, there's no cure. I know it's terrible, but there's no cure for it. But there's treatments divided into medications and non-medications, or pharmacologically and non-pharmacologically. These are the 6 aspects or domains for preventing and treating dementia. You should do this for all patients regardless if they get medications or not, and regardless of the type of dementia. It's been shown to help. And if you're at risk of getting dementia, if you do this, you will reduce your risk of dementia, hopefully, inshallah. So, avoid isolation, treat mental health disease. Obviously, the exact opposite and antithesis of what we're doing in the pandemic. And a lot of patients have suffered. A lot of my patients have suffered. Their dementia skyrocketed, their behaviors got worse, their delirium got worse. And so isolation is a very important risk factor. In fact, it's akin to smoking, I think, 10 cigarettes per day or something, which is terrible. Control chronic diseases, we talked about that. Avoid smoking and polypharmacy. Polypharmacy, again, meaning many medications, many complex medications. And as I just mentioned, you want to reduce anticholinergic burden in your patients. Exercise and sleep well. There's a lot of good evidence about this. The duration of sleep is actually quite important. Eat a well-balanced diet. There's no specific food that you should eat for this. It's a very common question I get. I don't know why. But there's some evidence about the Mediterranean diet being effective to some degree, but the evidence for that is, kind of mixed. Social stimulation, stimulation and mental stimulation too. So that means being active with your family and friends and your neighbors, talking to them, doing the things that you like doing on a daily basis. So if you like doing crossword puzzles, if you like using the computer, keep doing that. The more you do it, the more likely you will retain that information down the line if you get dementia. Medications. There's a very big class of medications called cholinesterase inhibitors. And these class of medications help potentiate the cholinergic activity in the brain, right? And keeps it more in the blood more so. And there's another medication, not in this class, called memantine as well. This is not a cure. And I spend a good chunk of my time with my patients and their families discussing these medications because they put all their hopes and dreams into this. And I know it's tough not to, but they're not a cure. They have moderate benefits at best. فائدة متواضعة is what I say specifically. And that your disease is going to progress regardless. But the key thing is the progression might lessen. So instead of progressing in a very acute fashion and in a few months you get worse and worse and severe dementia now, it might progress less. Keeping in mind, we haven't even talked about the side effects, which are plentiful. And that alone may stop someone from taking it. In fact, I'm in the school of thought amongst my department in Canada to look for reasons not to give these medications. For that reason alone, because you have moderate benefits at best and significant side effects. So I look for reasons why not to give it. There's a lot of political issues actually about these new medications coming out. Anti-amyloid drugs, there's a famous drug that just came out now in the US. The FDA approved it. And just because the FDA approved it doesn't mean it's correct, because we've gone through the evidence in my field. And in fact, the benefit is still moderate at best. And there's a lot of side effects that come with these anti-amyloid medications. Especially brain bleeding. And in fact, some physicians and healthcare providers in the US have quit because of this reason, because of political issues of them, this company and the FDA approving the drug, but really the benefits are minuscule and cause significant side effects. So it's a bit of a touchy subject. Antidepressants can help. I know they're called antidepressants like SSRIs, but they also help remedy a lot of the behaviors and psychiatric issues with patients with dementia. And antipsychotics we talked about just briefly before. BPSD, so this is a big broad term that means behaviors and psychological symptoms of dementia. So we talked about how in patients with dementia they have cognitive decline, right, in the many domains, and they have functional decline, but they also have behaviors and psychological issues as well. I'll touch upon that briefly. Everyone progresses differently. They may not have this, they may have one of it, they may have all of it. Medications are not the first line treatment at all. You have to apply non-pharmacological, non-medication means. This has been studied to death, and medications do not help treat the majority of these issues, and you have to apply non-medication means to remedy them. Antidepressants and cholinesterase inhibitor medications may help. And think of them like children. I know this is a terrible analogy to say, but if you have a child who's crying and can't communicate to you, you want to see if they need to pee or poop or eat or they're in pain, or you know what I mean? And so you want to address these basic needs first. And in an older adult with dementia, you want to make sure they don't have delirium, the acute confusion I mentioned before because of an infection or medication issue or metabolic issue or structural issue. Treat that as well. And then you can say, okay, these behaviors are because of their worsening dementia. And then you address those. And examples of BPSD or behaviors and psychological symptoms are these. They're not limited to these. I'm just mentioning some of them. But agitation, aggression, hallucinations, delusions, paranoia, depression, anxiety, and wandering. So, and actually in paranoia, the most common type of paranoia someone has with dementia is theft. شغالة سرقتني. She didn't. Or the second most common one is thinking that your loved one is cheating on you. Well, they didn't. The third most common paranoia is called phantom boarder, is you think someone is living with you, but they're not. And the fourth most common paranoia is poisoning. They think someone's trying to poison them. So again, in those very distressing psychoses, you might initiate antipsychotics, depending. I think I'll leave it at that for this slide. So correcting myths, I think from a public health perspective, very common things to mention to you. I mentioned this before. Not a part of normal aging. Dementia is a disease that needs a diagnosis and treatment. Do not do genetic testing. A lot of patients will say, well, I'm 60, 65, test me and my genetics for dementia. It's not how that works. Again, because the mutation that you get from Alzheimer's dementia in particular, if you have it, you may not get Alzheimer's dementia and vice versa. So not that good of a screening tool at all. Not everyone needs head imaging. As I said, head imaging helps rule out other causes of diseases, but technically if you have the bread and butter, straightforward Alzheimer's dementia, you do not need to do head imaging. But for non-geriatricians or non-neurologists or non-family physicians in this field, then perhaps do it to make sure. Cognitive testing tools, I mentioned this briefly. They're basically paper-based assessments that we administer to patients, something called MMSE or MoCA, where you test multiple cognitive domains in their brain with memory and saying specific words and so on. But it's a very common misconception where people think, okay, I'm going to give you this test, and if you score low, you have dementia. That's not the case at all. So if you score 15 out of 30, that's quite terrible. But you don't diagnose dementia based on that alone. This is a tool to help you make the diagnosis. As I said before, it's history, collateral, and functional decline that helps you make that assessment. Asymptomatic screening, a very common question. دكتور عمري 60 بفحصني للخرف. لا, that's not how that works, because studies have found that you have significant false positives. So we do not screen for asymptomatic patients. You only assess for dementia if a loved one or someone in their family or another physician has concerns over some cognitive domains or functional decline. Then you assess for it, sure. Herbal treatments, our culture loves this. Not good evidence about them. Not everything under the sun has been studied. The two most popular things are called ginkgo biloba and vitamin E. They don't work. They have many side effects. Don't do it. So 10 practical tips, and I think we have a couple of minutes to get right on time. So just a couple more minutes to go over these 10 practical tips for both medical students and healthcare professionals and the public. So just very briefly, we have 2 minutes to finish. Is that okay? Is treat chronic diseases. I mentioned that before. So diabetes, hypertension, high cholesterol, obesity. Have a family physician to review and touch base with families. I think is very important, and I think is a bit undermined in the kingdom, but improving. Identify resources around you. The Ministry of Health has been pumping lots of money and resources into this. We're opening clinics soon. We're becoming more older adult friendly in our units. And we also have lots of home care plans, al-inaya al-manziliya we call it, as well offered to patients. Identify BPSD, as I said. This is not them. You'd be surprised as to how many people think that this is their loved one or their personality that's acting this way, but it's not, it's the disease. So identify that this exists and that needs treatment. Avoid polypharmacy and many medications, especially if you have a cholinergic burden. So you do not want anticholinergics. Be aware of fake treatments. We talked about that briefly with the herbal remedies. Rule out delirium. Again, the acute confusional state. You cannot diagnose dementia if you have delirium. Treat that first and then assess later on if you have it or not. Identify safety concerns. I mentioned some of them early on. Acknowledge caregiver burnout. Again, a significant cause for distress and low quality of life if you have this. Many patients' families have this and won't even tell you. There's ways to screen for it, something called the Zarat Burden Scale when they come into your clinic. And lastly, your goal really is 2 things, because it's a complex issue, so it's difficult to really focus as to what you're trying to accomplish here, because it's a non-curable disease. But your goal is 2 things, is to have the best quality of life and independence as much as possible for that patient. And with that, I want to thank you for having me and thank the... I just want to say thank you to everyone here and for your attendance and for this brilliant idea about the mini med school. I think it's fantastic. I'm jealous we didn't have this many years ago when I was going through Alfaisal University. Ziad Ma'in and mashallah, the 25 plus group he has did a phenomenal job on this. So thank you again for all this. I enjoy medical education and teaching, and thank you for having me.
On behalf of myself, the students of Alfaisal Family and Geriatric Medicine Department, we'd love to thank you so much for this amazing and very informative presentation. Thank you so much.
Of course, my pleasure. Oh, thank you. Very kind. Jazakallah khair. Thank you so much. It's very kind. It's very generous.
And I think we want to open the floor for questions.
So if you guys now need to ask some questions for Dr. Hussain, please raise your hand, or you can use Menti to say your questions as well.
You gave me a gift, so you have to ask questions now. I'm not going to answer. Yeah, sure.
Would you give antipsychotics if the patient's wandering?
If the patients?
Is wandering.
No, excellent. That's been studied to death as well. So no, unfortunately, antipsychotics do not help with wandering. Ways to help someone who's wandering is to put a bracelet on them to track them, which I know can be a bit weird, but you can do that. Have a sitter with them the whole time to help out. Lock the doors, for example. Kind of deviate them from leaving. Just have someone there around. So essentially non-medication ways to treat wandering, but that's been studied specifically about antipsychotics and wandering, and it does not work. And in fact, the majority of BPSD features are not treated with antipsychotics. Good question.
So what about the investigation about the border? They think someone's living with them and not?
If it's distressing, so technically, and the question was, what if someone has a paranoia about phantom boarder or someone living with them? And that's a type of paranoia, which is a type of psychosis, which is distressing to them. So if they're distressed and they're like, someone's living there, I can't sleep, I'm not going to talk, I'm not going to eat, I'm worried to death, initiate antipsychotics. But if they're like, someone's living here, I'm going to go take a walk, who cares? That's fine, it's not distressing per se. So not because they have a psychosis, give antipsychotic. It's a distressing psychosis, and in your example it is, so I would. Good question. Yeah?
I've heard cases in which normal pressure hydrocephalus is confused with Alzheimer's disease. So if we're to avoid always taking scans or images of the brain when we're trying to diagnose Alzheimer's, then how do doctors in your profession or in your area avoid making misdiagnoses when clinical symptoms look similar?
Between MPH and Alzheimer's? Well, that's a brilliant question. You guys are so smart. You're asking, honestly, I'm not just being nice, you're asking resident level questions. So NPH stands for normal pressure hydrocephalus, which is when the CSF in your brain, in your ventricles, are abnormal and have gotten significant, but the pressure there is normal, that's the name, but causing hydrocephalus or enlargement of the ventricles, which can cause disease. Namely, what you said, it can cause dementia, not Alzheimer's, but a form of dementia, urinary incontinence, and gait problems. So if you have that triad, then that goes more with NPH. If not, then perhaps Alzheimer's dementia. And now if you do the head imaging, you can see if they have enlargement of the ventricles or not that is in keeping with NPH, because in Alzheimer's patients, they don't have large ventricles. There is a bias though, because as you age, you have brain atrophy and thinness of the brain around, and so the ventricles look large. We call that ex vocuo. So it's pseudo enlargement of the ventricles. They're not really enlarged, but they look bigger. So the radiologist has to be careful in assessing that. There's ways to differentiate, but what I'm trying to say is really history, your physical exam, your gait assessment, the urinary incontinence perspective, the duration and decline in cognition in Alzheimer's is very, very slow over months and years. In NPH, it's more subacute.
You were mentioning how we should try and catch them before the dementia progresses really badly. But then you said asymptomatic screening, we can't do that. So what is going on?
What do you mean? Yeah, good point. I was being very wishful, so that hopefully in the future we can do this. In the future, the aim is to catch patients who are going to get dementia, but right now are asymptomatic and do not have these features, but we don't have a way to assess for them yet. So currently we're only assessing patients who have cognitive decline, who have functional decline, and then catch those. But that's at the far end, as I said in the graph, where they already have dementia. So you want to catch them when they're normal, but make sure they will get dementia and intervene here when their brain is still healthy, not when it's inflamed and damaged already. But we haven't gotten to that point yet, so inshallah in the future you'll come up with something to help us catch those patients. That's okay. Sure, that's perfect. I'd love to. Thank you for having me. Yatlakum al-afiyah.